Ladies and gentlemen, please welcome AACP President Peggy Piasek.
Good morning and welcome to the Gaylord Texan Resort. I am pleased and privileged to lead the opening general session for the 2014 AACP annual meeting. It's great to see all of you, so many old friends and new faces from around the United States and around the world. Participation keeps getting stronger as we expand our programming and add new features. We're happy to host all our first-time annual meeting attendees. We know you'll find many ways to learn and connect during these few days and many ways to enhance your careers once you return home. And to those who attend year after year, I know you'll appreciate what doesn't change, notably the networking opportunities that allow you to catch up with old friends while making new ones, and of course, the most comprehensive educational program in academic pharmacy. At the same time, I'm sure you'll enjoy the new features this year, more mini sessions, the new R&R Lounge, and the mobile app, which will make your time productive and enjoyable. This year, we had a record number of submissions for mini sessions, and we are offering 28 of them and added CE for nearly half. The AACP program committee members, now displayed on our screens, have certainly done a tremendous job, and we'd like to thank these outstanding volunteers for their work. What's new? I mentioned the expanded mini session offerings. Another addition is the R&R Lounge. We know that taking care of business also means taking care of yourself in the process. So when you need a brief break, you'll have a place to kick up your feet, check your email, charge your electronics, or just unwind. Sip some fruit water and get ready for your next session or appointment. We're also excited about our new mobile app, which allows you to customize your meeting experience and also connect with colleagues. Just a reminder, in a few minutes, we'll recognize the Chalmers and Weaver Award winners. The Dawson and Vollweiler Awards will be presented at the Science Plenary on Monday. We have an impressive lineup for the closing banquet on Tuesday evening. In addition to our traditional presentation of the Lyman Award, we will present the Distinguished Service Award to Walmart. The 2014 Student Community Engaged Service Award will also be presented. I'm sure that many of you are eager to extend your engagement in the annual meeting by tweeting your thoughts. Our Twitter information is shown on the screens. We have a very special group to thank for contributions that make the annual meeting possible. Our sponsors, now listed on the screens. I ask everyone to join me in a round of applause to express our deep appreciation for their generous support. The AACP annual meeting is always about celebration, a celebration of pharmacy education. This year we begin by celebrating two important milestones, two 10-year anniversaries. For 10 years, AACP has benefited greatly from the support of the Walmart Corporation, and specifically our partnership in the AACP Walmart Scholars Program. The company's leaders recognize the importance of building the next generation of pharmacy faculty to ensure that employers have sufficient numbers of talented pharmacy graduates. In recognition of their important contribution to academic pharmacy, we are honoring Walmart with our 2014 Distinguished Service Award. This morning, I would ask that everyone who is attending as a 2014 AACP Walmart Scholar, along with their mentors, please stand and be recognized, and that anyone who has attended in the last 10 years as a scholar, mentor, or both, please stand so we can applaud you. This year, we also celebrate the 10th anniversary of the Academic Leadership Fellows Program. Since its beginning in 2004, this program has helped nearly 300 of our most promising pharmacy faculty prepare for roles as future leaders in academic pharmacy and higher education. What an achievement. And now, continuing our list of celebrations, I am pleased to begin the award presentations this morning. First, the Robert K. Chalmers Distinguished Pharmacy Educator Award, given since 1981 to recognize excellence in pharmacy education. This year, we honor Robert L. Talbert, PharmD, B.S., Smith Klein Centennial Professor of Pharmacotherapy in the College of Pharmacy at the University of Texas at Austin, for his excellence as a teacher, his outstanding achievements as an author and mentor, and his overall impact on pharmacy education and the profession. Dr. Talbert also holds an appointment as a professor of medicine at the University of Texas Health Center in San Antonio. He is responsible for didactic and clerkship teaching of baccalaureate and PharmD students and supervises activities of these students on the medicine service at University Hospital in San Antonio. Bob is also an accomplished scholar and leader, having contributed through research and publication in more than 150 peer-reviewed manuscripts and more than 50 books and book chapters. He has served numerous organizations at the local, state, and national level on committees and in elected office. This includes service to AACP and presidential leadership for the American College of Clinical Pharmacy. In 2006, Bob received the Distinguished Service Award from the American Heart Association's Texas affiliate, and in 2007, he was named recipient of the Russell R. Miller Award from the American College of Clinical Pharmacy for substantial contributions to the literature of clinical pharmacy. In typically modest fashion, he said that the greatest reward of his teaching career has been seeing the accomplishments of former students, residents, and fellows, many of whom who have gone on to achieve national and international recognition. His advice to young pharmacy educators is to become passionate about learning, teaching, and helping others. Bob, please join me on stage.
It's been a humbling experience, and it has caused me to reflect back on a 40-year career at University of Texas, 1 year at University of Nebraska, and sort of realize how important others have been in the receipt of this award. I started in pharmacy when I was about 15 years old in Hopkins Drug in Carlisle, Kentucky, sweeping out the floors before school in the morning and stocking shelves in the afternoon. The first thing is being willing to take on new challenges. The challenges are always there. They are different from time to time, but being able to recognize and take on new challenges. The other things that I think have been important are networking. You don't do much by yourself. It's really through your colleagues and your friends, your family, that enable you to be able to do things that you could not do on your own. It's been a lifelong pursuit of knowledge and excellence, trying to be the best that you can possibly be, and looking for new challenges to take on all the time. Find something that you're passionate about, pursue that passion, be prepared as best you can to accept the challenges as they come along, seek others to help you along the way, to be mentors to you, to be colleagues, and look for every opportunity.
Wow, how exciting. This is absolutely wonderful.
I am honored and deeply humbled by receiving this award. I'd like to thank a number of people, starting with the award committee for nominating me and for the board of directors for selecting me as the recipient of the Robert K. Chalmers Award. Special thanks goes out to Leah Island, who was one of my former students who nominated me for the award and essentially kept on my case to make sure I got all the paperwork in on time, which was no small thing. I'd like to thank three kings. No, wait, I mean deans. Pretty much the same thing. Jim DeLuzio, who recruited me to Texas, who is a force to be dealt with even today, and a guy, I think, that provided leadership for Texas when Texas needed leadership. He took a third-tier school to a first ranking in the entire country, was excellent at recruiting, as you can see. To Steve Leslie, my second dean, who was always very supportive. He was very empathetic and was an excellent listener. And then lastly, to Lynn Chrisman, who I would call the thinking man's dean. I'd like to thank my faculty colleagues, and there are too many to really mention them by name, but without their help and encouragement and guidance, I would not be standing here today. I'd like to also say thanks to my students, many of whom have gone on to have incredible careers, and I'll just give a couple of examples. Jean Nappy in South Carolina, Julie Johnson at University of Florida, Bruce Mueller, who I saw earlier here at this meeting, but just dozens and dozens of people who have gone on to become stars in their own right, and I'm so proud of what they have done. And then lastly, to my family, my sister, Jane Talbert. Jane, would you please stand? Thank you. And to my wife of 39 years, who I love dearly, Betsy Talbert. Thank you so much for this award. This has been a terrific life and ride. Thank you so much.
And I hope you all noticed that he is a native Kentuckian. The Lawrence C. Weaver Transformative Community Service Award recognizes significant institutional commitment to addressing unmet community needs through education, practice, and research. The award highlights community service as an important element of the academic mission and singles out institutions that serve as examples of social responsiveness on the part of the academic health professions community. Our 2014 recipient is the University of Oklahoma College of Pharmacy, recognized for their deep and consistent commitment to community service through initiatives such as the OU Physician Community Health Evening Clinic, an interprofessional, student-based clinic that focuses on providing care in underserved areas of Tulsa and rural Northeast Oklahoma. Let's take a look at the program in action.
The many initiatives we serve the community through are as diverse as the individuals that make up this college.
Altruism is a way of life at the OU College of Pharmacy. Community service is more than a catchphrase, it is indeed a core belief.
We look mostly for partners who will allow us to define our profession at its fullest expression. We are most interested in those partners who like to collaborate with us to develop new practice models that are creative and innovative so that our students can see it can be done and can participate in the doing of it.
We've observed that the service activities students participate in while they're in pharmacy school sows the seeds that as they transition to pharmacists and enter their professional careers, they sustain a desire for service engagement with the goal of making a positive impact in their communities.
OU Pharmacy definitely does encourage students to be involved in the community. The faculty here are so supportive of any community service activities that we do.
Sustaining community programs definitely takes hard work and dedication. Our students are involved throughout the process and learn valuable leadership skills, and our faculty are involved by providing advice and support. We believe in solid teamwork.
Since opening as the Bedlam Clinic in 2003, the clinic has conducted consultations with more than 10,000 patients, 95% of whom do not have health insurance. The clinic, which was initially open from 6 p.m. to 10 p.m. 2 evenings a week, has grown to include 20 school-based clinics, a mobile clinic, and a daytime Bedlam longitudinal clinic to help better manage chronic diseases. A minimum of 3 physicians, 4 medical students, a pharmacist, 2 student pharmacists, 2 nursing students, and a nursing faculty member are on site to run the clinic. More than 275 student pharmacists have earned IPPE service hours through the clinic since its creation 5 years ago. Accepting the Weaver Award on behalf of the University of Oklahoma College of Pharmacy is Dr. Jolene Dragalis, Dean and David Ross Boyd Professor at the university, an AACP past president and a past Chalmers Award winner, and her team. As evidence of how Jolene and her faculty collaborate with colleagues across the Academic Health Center, Dr. Lizelle E. Benefield, Dean of the College of Nursing at Oklahoma, came to Grapevine this morning to celebrate with our Weaver Award recipients. Lizelle, welcome. May I ask Jolene and her team to join me on stage.
It is indeed an honor to accept this award on the behalf of the University of Oklahoma College of Pharmacy. I want to thank the Argus Commission, the Board of Directors, and the site visit team members for their deliberations in regard to this award. Even a snowstorm and a closed campus announcement during the site visit last November couldn't dampen our excitement to share what's happening at our college. For us, community service is definitely a core belief. Our college has a history of, a commitment to, and a heart for community engagement. Our culture provides for sustainability of initiatives, while the creativity of our students and faculty drives us to start new projects. Personally, I have a deep appreciation for almost any quote by Coach Vince Lombardi. He once said, "It's an individual commitment to a group effort. That is what makes a team work, a company work, a society work, a civilization work." The receipt of the Weaver Award recognizes the contributions of hundreds of students and faculty members across the years in a variety of service initiatives. I'm so proud of their work. All of them are being represented on stage with me today by Dr. Jane Wilson, Associate Dean for Students and Award Dossier Creator, Dr. Mark Britton, Senior Associate Dean for Academic Affairs and Professional Programs, and Dr. Mike Smith, Assistant Dean for Tulsa Operations. Also, I would like to ask all other OU representatives in the office to please stand and be recognized. Our faculty, staff, and students look for avenues to live out our identity as a prescription for inspiration. Inspiration doesn't just happen. It can only flourish in an environment of creativity. On behalf of the University of Oklahoma College of Pharmacy, thank you for this honor.
And now for a change of pace.
I bet you're all awake now. 12 months ago, as I came out of the starting gate for my presidency, I outlined the association's priorities for the coming year. I would like to spend the next few minutes talking about the incredible work done by our members across the Academy over the past 12 months. In March, our association's leaders gathered at the Mount Vernon Leadership Institute, where we were inspired by the personal integrity, creativity, dedication, and persistence against great odds of our country's first president. George Washington is the perfect example that you can lose a battle, or in his case, many battles, and still win the war. Last night we celebrated 2 leadership milestones. I've already mentioned the 10th anniversary of the Academic Leadership Fellows Program. We will honor this year's ALFP cohort at their commencement on Monday. Included among the ALFP graduates is the recently named 7th AJPE editor, Dean Gail Brazeau of the University of New England College of Pharmacy. Gail succeeds Dean Joseph DePiro of Virginia Commonwealth University, who has stepped down after 12 very successful years of growth for the journal. We will present a special tribute to Joe at the closing banquet. We also celebrated the inauguration of the Academic Research Fellows Program, which will soon complete its first year. The program is designed to expand the leadership capabilities of established faculty research scientists and administrators, to cultivate collaborative team research and graduate education across institutions. A vitally important activity that continues through 2014 is the comment period for the ACPE Draft Standards 2016, which will incorporate the CAPE 2013 educational outcomes released last July. The AACP Board of Directors has established a committee comprised of board members and members at large to collect input from sections, SIGs, and individual members. ACPE will host a listening session at this meeting on Monday at 8 a.m. I encourage you to attend and participate in this discussion. You are also invited to complete the AACP survey for individual members. A link is provided in the July 16th alert. The survey will remain open until August 11th. And of course, you are also invited to provide feedback directly to ACPE via their website. And speaking of the CAPE 2013 effort, I am pleased to recognize on behalf of the AACP Board of Directors, Dr. Melissa Medina from the University of Oklahoma for her service above and beyond in so many ways. Melissa served as chair of the 2013 CAPE educational revision process that spanned 15 months. She skillfully guided the talents of the outstanding panel to produce the exceptional guiding document for our curricular consideration for years to come. With her unique educational background, passion for pharmacy education, and enthusiasm for AACP, Dr. Medina helped lead the panel to an expanded version of CAPE beyond the cognitive and into the affective domain. Dr. Medina also served as a key planner and facilitator at the very successful May 2014 AACP Institute, which will be repeated in November due to popular demand. As one attendee wrote in their Institute evaluation, Melissa can make shoveling dirt seem exciting. Join me in thanking Dr. Melissa Medina. The theme for the 2013-2014 year has been the relentless pursuit of excellence, and the work of our standing committees has truly been excellent. The Academic Affairs Committee, chaired by Jeff Kane, my colleague from the University of Kentucky, explored opportunities for developing an online platform for courses across the Academy, the role of serious gaming in pharmacy education, the adoption of learning analytics to maximize big data for programmatic and curricular purposes, and how to best value scholarship related to emerging technology in our schools. The committee recommended that AACP develop serious games to be used in health professions education. The committee report states that educational games require students to actively learn by forcing them to make decisions for determining game strategies and solutions. The playing of games is known to stimulate curiosity and interest, and also has the potential to generate enthusiasm, encourage competition, and increase student engagement. AACP's gaming initiative, Professions Quest LLC, is on track for the release of its first game in early 2015. Mimics will be the first multiplayer interactive game for interprofessional learning. You will have an opportunity to learn more about Professions Quest and Mimics at the AACP booth in the exhibit hall. Don't miss it. The Professional Affairs Committee, chaired by Miriam Mobley Smith of Chicago State University, took on the important task of examining pharmacy technician training and the role of pharmacy schools and colleges in preparing these essential support professionals for their evolving role in healthcare. For pharmacists to achieve the newly updated JCPP vision that patients achieve optimal health and medication outcomes with pharmacists as essential and accountable providers within patient-centered, team-based healthcare, it is essential that pharmacy technician workforce is prepared to take on new roles in pharmacy practice. Academic pharmacy must make it a priority to become involved at the national, state, and local level in efforts to formalize education, training, and certification of all pharmacy technicians. Academic pharmacy needs a greater level of involvement to help ensure that all professionals engaged in these efforts are qualified to do so. Some schools and colleges of pharmacy and pharmacy technician programs have developed collaborations to advance pharmacy practice. However, many schools of pharmacy have not considered the value of establishing these partnerships. We have many avenues to explore with our colleagues in pharmacy technician education and training as healthcare and pharmacy education continues to advance. The Advocacy Committee, chaired by Hershey Bell of the LECOM School of Pharmacy, and the Research and Graduate Affairs Committee, chaired by Lauren Bloodworth of the University of Mississippi, worked synergistically in the area of community engagement. The Advocacy Committee developed evidence-based issues briefs that identified strengths and barriers to overcome in the areas of health and wellness, community engagement, and the scholarship of engagement. These valuable resources are available for use by schools and colleges to enhance the visibility, value, and importance of pharmacy and pharmacists in individual and population-level outcomes through our education, research, and service efforts. The Research and Graduate Affairs Committee immersed themselves in a study of community-engaged scholarship. Their report provides a series of recommendations to promote and enhance our work in the scholarship of engagement. The recommendations include networking and collaborative efforts among institutions, development of courses or certificate programs to formally train community-engaged scholars, advocacy for increased funding opportunities, and development of promotion and tenure guidelines to codify recognition and reward to faculty whose work advances the institution's mission and benefits communities. The Special Committee on Admissions, chaired by Andrea Wall of the University of Cincinnati, has finished year one of their two-year charge to evaluate the spectrum of activities related to pharmacy student recruitment and admissions. A number of resources and recommendations will come forward from this group, including educational resources available to pre-health advisors, recruiters, students, and the public to enhance their understanding of pharmacy and pharmacy education. Current pre-pharmacy competencies and curricula are being evaluated to assure that our entering students are prepared for the challenges of a rigorous curriculum and professional practice. The committee will also provide information regarding best practices, implementation, and evaluation of holistic admissions to ensure that our graduates are not only academically qualified, but are equipped with the skill set necessary to serve a diverse population. Over the past year, the Council of Faculty's Faculty Affairs Committee, under the leadership of Robin Zevad, Midwestern University, and her 3 co-chairs, Andy Traynor, Concordia University, Kristen Yankee, University of Minnesota, and Mary Stamatakis, West Virginia University, have developed a Distinguished Teaching Scholars Program to recognize scholarly teaching and the scholarship of teaching and learning within the Academy. This fulfills the recommendation of the 2011-2012 Academic Affairs Committee to recognize our outstanding teaching scholars. These scholars will serve as role models and leaders in furthering the scholarship of teaching and learning in pharmacy education. We anticipate the first group of scholars will be awarded at the 2015 annual meeting. More information will be provided later during a special session on Tuesday afternoon. Another important program launched in 2014 is the Master Preceptor Recognition Program, designed to recognize preceptors on whom we depend for such a substantive amount of teaching and learning. This new program, funded in part by the National Association of Boards of Pharmacy Foundation, recognized preceptors from 7 NABP AACP districts. I am particularly pleased to report that NABP will again contribute funding for the 2015 Master Preceptor Recognition Program, and they will be joined by the American Society of Health Systems Pharmacists and the National Association of Chain Drugstores. I always look forward to the work of the Argus Commission, the committee comprised of the past 5 AACP presidents. The commission takes on relevant big-picture topics in healthcare and education and provides the Academy with a thought-provoking examination of the issue. This year, I asked Dean Emeritus Vic Yanchik of Virginia Commonwealth University and the commission to answer the question, how can we more effectively address and serve the diversity in our population at both the institutional and individual level and prepare our learners to serve an increasingly diverse population of consumers? The commission looked broadly across the issues, including societal diversity, the applicant pipeline, current students, pharmacy faculty, AACP, and our member institutions. The commission also considered the work of Scott Page, who has written about the value of diversity of thought and perspective. A strength of AACP is the diversity of our members' perspectives and experiences that we share, discuss, and debate at our meetings and throughout our publications. The commission recommends that the Academy impanel a task force on diversity and inclusion to advance our diversity goals. As I cross the finish line of my presidential year, I would like to thank the hundreds of our volunteer leaders who have served on the committees across the association this year, as well as Lucinda Main and the AACP staff for their truly excellent work over the past 12 months to make this a most productive year at AACP. And thanks to all of you for the honor of allowing me to serve as your president. Now it gives me great pleasure to introduce our keynote speaker, Ian Morrison. Dr. Morrison is an internationally known author, consultant, and futurist, specializing in long-term forecasting and planning, with particular emphasis on healthcare and the changing business environment. This morning, he will talk about the political, economic, and strategic changes in healthcare, including possible scenarios and how we can prepare for the future. Please help me welcome Dr. Ian Morrison.
Good morning. Well, what a pleasure to be here, and thank you for the invitation. I'm a professional futurist. My definition of a futurist is an economist who couldn't handle the calculus, basically. You know, I'm in the sweeping generalization business. You know, you may detect I live in California, but I'm not a native Californian. My only qualification really is I'm a Scottish-Canadian Californian, which gives me a unique perspective on healthcare and all things to do with healthcare, including death and dying, because The Scots see death as imminent. Canadians see death as inevitable. And Californians see death as optional, actually. Really, we don't do it. So my business model is I come in for a day, insult people, and leave, right? You know, it's a bit like Newt Gingrich, only at a lower price point. But so I've had an interesting week. I'm the moderator every year for the American Hospital Association's Leadership Summit. So we were in San Diego last weekend with Secretary Robert Gates here, who was at Texas A&M, as you know, before becoming Secretary of Defense. We had Malcolm Gladwell and Peyton Manning and Dr. Ben Carson, so that was fun. And then I went off to Montana to moderate a group of private equity guys who are beautiful people. No, they are actually very nice people. And a bunch of CEOs talking about where the industry's headed. So I've got all that stuff in my head. The other thing I would bring to the party, I guess, is that I have a partnership with the Harris Poll and the Harvard School of Public Health. And what we do, we serve we have a service called Strategic Health Perspectives, which is supported by many of the large pharmaceutical companies and people like Kaiser, United, GE, and heading off to Chicago to meet with that group this week. But we survey all the stakeholders in healthcare, physicians, consumers, health plans, hospitals, and try and make sense of what's happening. So what I'm going to share with you is based on not only rattling around and interacting with a lot of leaders in healthcare, but also some data. But most of what I'm going to share with you I just made up, to be honest. So I'm going to do this very quickly and hopefully give you a sense of what some of the key issues are that leaders are facing. I'm going to talk a little bit about the quest for value and do that in an international context, and mention a notion, a book I did many years ago called The Second Curve, which is used a lot in the healthcare system with leaders to describe what is going on. This movement from volume to value is the short way of putting it, moving from a fee-for-service oriented system towards more of a system that rewards value. And then I'm going to take you on a drive quickly through what I think some of the forces are, political and economic, for healthcare as we look out to 2020. And I'm going to really take you through from the perspective of people who pay the bill, both public and private, and mention a little bit about what this is all meaning in terms of the transformation of delivery systems. So a little bit on delivery system, a little bit on what academic medicine might look like, and specialty pharmaceuticals is a big topic I will cover very, very briefly. So that's a quick drive-by that we're going to cover over the next 45 minutes or so. Does that seem like a sensible way to spend some time? Good, because that's the slides I brought. So what's going on? Well, obviously the Affordable Care Act is the big story. It's the law of the land. People have to implement it. There's this sort of passive-aggressive attempt to bring it down in part of the country using legal challenges. But we really have two Americas. One America, I live in California, where we're rapidly expanding Medicaid and we're aggressively pursuing our own state-based exchange. Texas is the other example where there is no expansion of Medicaid. Medicaid is relatively restrictive in this state. There's not been a lot of support for the federal exchange by local officials. And despite that, 750,000 people in Texas signed up for the exchange. 1 million people in Florida did. So we have two Americas with very different systems, different politics, different ideologies. Public exchanges got off to a very rocky start. That's the mother of all understatements. It was a disaster. And they kind of pulled it out in the fourth quarter. And I'll show you some numbers about that in a second. The other thing not to miss is that private exchanges are growing quite rapidly. By some estimates, we have 3 million Americans in these private exchanges, and these are models, these are run by benefit consultants like Towers Perrin, Crosby, Stills, Nash & Young. And what they do is provide a vehicle for large employers, or small employers for that matter, to migrate from defined benefit to defined contribution, much in the same way that they did with pension 20 years ago. The relevance of an exchange purchase is that people are buying with their own money. And when people buy with their own money, they pick cheap. And they tend to buy down benefits rather than buy up. And I'll show you the data on that. And it moves the market more towards retail. In the delivery system side, what we're seeing, accountable care is the mega trend. Maybe not CMS's ACOs. One of my dear friends, Bob Margolis, said to me in the weekend when we were up in Montana that Medicare CMS is ACOs are a bad idea, commercial ACOs are a good idea. And that may be how the market shakes out, excuse me, over the next couple of years. What many large health systems leaders are figuring out is if I'm going to go to the trouble of managing care through a shared savings program, why wouldn't I want to get a bigger share of the premium dollar? And the way to do that is to engage directly in Medicare Advantage, and we're seeing more and more health systems go in that direction. No matter what, we're going to see pressure on costs and delivering value intensifying in the American healthcare system, and enormous scrutiny on hospital prices. Particularly by both the press and the public, because of the enormous variation in commercial prices for services. There's a tenfold variation in California in colonoscopy prices, in surgical prices for hip and knee replacement, for example, and you're going to see that price variation, I think, constrained substantially. Many institutions are learning to live on Medicare, which means that this is an aspirational goal because very few hospital systems in America can actually make money on Medicare. But what we're seeing is many health systems are aspiring to do that, and it means they have to take 20% costs out, much, much more if you're an academic institution. The movement from volume to value is moving rapidly, and in fact, if you take it quite literally, you're moving from fill in the hospital to empty in the hospital. And this is happening dramatically, particularly in the Midwest, where volumes are down 3 to 5% every single year, and it's not coming back on an inpatient basis. And if you are really truly moving towards a world of capitation, all of the assets that were valuable assets, like marginally indicated cardiovascular surgery or cardiac catheterization or hip and knee replacement that was really not indicated, become liabilities in a world of capitation. And that's really an important shift in mindset that's going on in the marketplace. The other thing that everyone violently agrees on is we need to focus more on primary care. Just one wee problem, nobody wants to be a primary care doctor anymore. Apart from that, it's a genius idea, right? So the other thing we're seeing is a massive consolidation into 100 to 200 large regional health systems. Now, I'm not saying independent doctors won't exist anymore or that small hospitals can't survive on their own, but what I think is true is that today, if we had honest accounting of it all, and we don't really know, because this is not the way we keep the books, but probably about 40% of the American healthcare delivery system is flowing through these top 200 systems today. That number is rapidly moving towards 80%. So there's greater concentration. Doctors are running to hospitals to huddle for warmth, given the uncertainty. Hospitals are consolidating regionally. The role of private equity and for-profit plans, for-profit organizations is significant in the consolidation. And there's a sort of pushback from the purchasers who are very concerned that these behemoth systems like Partners in Boston, who own 30% of the healthcare delivery system in Massachusetts, have so much power that they have pricing power on a monopolistic basis. So there is pushback on that. One of the reasons why this is happening is not just because of the Affordable Care Act, although that's used as an excuse for some of this, is because the bond market believes if you're bigger, you're better. And so the financial pressures on CEOs of these systems is to start to build something that's sustainable. And when you start thinking about, we're going to get into population health, we're going to become a health plan, you can't do that if you're a 100-bed hospital in the middle of nowhere. And so I think we're going to see this consolidation continue. But it also means that one of the big jobs these larger integrated systems have is standardizing care processes, driving out variation, and doing it in a fairly ruthless basis. And that's why you're going to see more and more control over clinical practice exerted by these large integrated systems. Now, one of the reasons why we've got to do all of this is the people that pay the bill are not very happy campers. And I'll take you through, I spend a lot of my time advising employers, particularly the Pacific Business Group on health, and they are not happy campers, and I'll tell you some stories about them in a second. What we do know, and I think this is where clinical pharmacists can play an enormously important role going forward, is that we do a very poor job of care coordination in the American healthcare system. And we do it badly in almost every health system. It's particularly bad in the US. And I think that's going to be at a premium going forward as we move from volume to value. But it's not going to be easy work. It is culturally challenging. And the real question is, will doctors and consumers come along with all of this? But here's the punchline, if you want to nod off for half an hour. No matter what, we're going to have to redesign the American healthcare system to be higher performing. It is not higher performing today, and it needs to be science-based, it needs to be technology-enabled, and it needs to be consumer-friendly. And we have a long way to go. And that's why I think the focus has got to be on value. I have the honor of teaching in a program run by Berkeley every year called the Global Health Leadership Forum. And this is for people who are going to be ministers of health in their countries someday. And they come from all over the world, from rich and poor countries like Ghana, Nigeria, or rich countries like Singapore and Sweden. And my little lecture is around this equation. And it's really interesting. Even people of very different backgrounds, if you show them an equation like this, they nod their head, because this is exactly the equation they're trying to solve for in their healthcare system. They're trying to get as much access as possible of highest quality. And by quality, I don't mean atriums or fancy buildings or actually fancy machines. I mean health outcomes, health status improvement, health gain is the term a lot of Europeans use. And the other factor is security of benefits, and that's the one they struggle with. I mean, we're the only developed country where you can change your job and lose your health insurance. I mean, that just doesn't happen anywhere else in the developed world. And then the denominator, of course, is cost. Now, I think we all know that we spend more than everyone else. I mean, we have a poor value largely because of the denominator, and you've seen these data, I'm sure, before. You don't always see it broken out this way, where the light blue is public spending and the white is private spending and the dark blue is out-of-pocket costs. I mean, what you take from this is we have the largest government-run health system in the world. We just have another 7% of GNP on top of that compared to other countries. Now, this is slightly dishonest because I left out Norway. Now, Norway, I don't know if you've been there, but it's an odd place. It's a cross between Sweden and Saudi Arabia, right? It's socialists with oil. So the way the Norwegians roll is they run a 7% of GNP surplus every year. They have enormously high taxes. They throw a ton of money at their health system, and they pay down their debt. We Scots, by the way, we aspire to get our independence in September this year. We've got the same plan. We're going to use our share of the North Sea oil money, but instead of paying down our debt, we're going to give free whiskey to everybody, We'll have a great party for 2 years, spend all the money, and then beg the English to take us back, right? Look it up, it's on the Scottish website. So we spend a lot, we all know that, but what bothers me is the other side of the trade. We don't get a lot for it. And I'm going to show you a bunch of PowerPoint slides but this is the one that bothers me the most. This is mortality amenable to healthcare. And those of you who are clinical, most of you here, what it is technically is age-standardized death rates before age 75 for conditions where timely effective medical care, particularly pharmaceutical care, can make a difference, including ischemic heart disease, diabetes, stroke, and bacterial infections. We rank dead last, right? Not good. If you're not clinical, dead ain't good as an outcome, right? And what we know, oh, by the way, I should say, we're last. Look who comes out number one, the French. Now, look, I love France. I go to France every year. I think the French are great. I think their healthcare system's pretty scruffy, actually. But the reason they do well in this measure has got absolutely nothing to do with medical care. It's because they walk, they drink red wine, and they get naked in the summer, right? Nothing will keep your BMI down better than getting naked in the summer. Some smart aleck in London figured out this data point, and what he did was he put every blue dot in this chart as a country, and this is life expectancy against spending. And you can see we're a complete outlier. Interestingly, there are 3 countries, the US, Denmark, and Chile, who have exactly the same life expectancy. The Danes spend half of what we do. The Chileans spend 1/8 of what we do. So it's not terrific. Now, when you look within the US, we have similar kind of variation. The Commonwealth Fund's done a great job. You can go look at dig all this data up, and they've put all the value things in the equation into one measure. So dark is bad, white is good, and you can see variation across the country. And it tends to be states that have poor performance, have ironically not expanded Medicaid, have relatively restrictive Medicaid. So a lot of this has to do with the uninsured rate. But also, if you look at the measure we just looked at, the French do well, the Americans do badly, there is this distribution across the country in mortality amenable to health care, where the difference between the best state and the worst state is a 2-fold difference. That's pretty alarming in terms of variation. So we've got half of the country who really have health status of the French, and the other half are very, very bad. And again, it has troubling differences by race, linking back to the comments made earlier about diversity. Now, one of the reasons why we have poor performance is we have barriers to care that are financial, and that is very different from other countries. 37%, and this is data from the Commonwealth Fund, 41% of folks have spent more than $1,000 out of pocket on healthcare, and over 1/3 have experienced some cost-related access problem, including not filling a prescription because of cost. That's a fairly common thing. And people say, yeah, but we have much better access to care. Well, that's really not true anymore. You have to wait for appointments here. And in fact, countries like Germany and New Zealand and Holland have done a good job of making available same-day service for their citizens. And waiting times are bad in Canada, to be sure, but they're not terrific in the US. And what we see is that there are significant proportions of people who have to wait 6 days or more for an appointment. Waiting time, and we always sort of comfort ourselves, well, we can always get in to see a specialist, and that's true. Very few people wait 2 months or more, but there are other countries who can do it relatively quickly as well, including the UK, who have done a remarkable job. And by the way, if you look at the latest Commonwealth Fund analysis of 11 countries, the UK ranks #1 across a whole series of measures. America's last, Canada is second to last. So we're not performing well, and this is the one that bothers me the most, and this is one of the reasons I think why we have poor performance, is access to after-hours care. On the left-hand side, it's asking the public, how easy is it to get after-hours care without going to the emergency room? Again, we don't do particularly well. We're better than Canada and France, but we're not as good as the UK. And on the right-hand side, we're asking primary care physicians, or the Commonwealth Fund is asking primary care physicians, does the practice of an arrangement for patients of after-hour care, we're dead last. Look, you can get a cheeseburger anywhere in America at 3 o'clock in the morning. You can't get in to see a primary care doctor at 6 o'clock at night. That's a big issue, and access to primary care, I think, is a huge problem going forward. But in terms of pharmaceutical care, I look for some of the measures that might relate to things you're interested in, and the US is in the middle of the pack in terms of physicians routinely receiving electronic prompts about potential problems with a drug dose or interaction. So we're behind some of the other countries who have nationalized systems of doing this. And we're the worst country in terms of the hassle factor for physicians in prescribing medications, where the percent of physicians say it's a major problem. About half of doctors in America say it's a major problem to get the medication for their patients. So access, I mean, you're all about access and appropriate use of pharmaceuticals, and you can see relative to other countries, we're not performing particularly well. One insight, though, is that these differences depend on what style of practice takes place. In larger integrated systems, and this is just breaking it out by, are you in a sole solo or individual practice with another doctor, or do you have 5 or more FTE docs? The larger the practice, the more likely you are to have some of these measures go in the right direction. So that's an insight, I think, about change. And it's one of the reasons why we're seeing this migration in the health system from the first curve to the second curve. Now, I won't go through all of the sort of implications of this that the book laid out, but I worked for and ran a group called the Institute for the Future, the modestly entitled Institute for the Future in Menlo Park, California. And we were doing a lot of work with a lot of industries that were in transformation back in the 90s. And we came up with this concept. And the argument is embarrassingly simple. The argument is that most businesses in most industries are going along quite nicely on the first curve. It's the business they know how to operate on a daily basis. It's where they make all their profit and revenue. But they have a sneaking suspicion in their gut that it's going to decline in absolute or relative terms. So the red line coming down might not be revenue declining. It might be growth rates or gross margin, and be replaced by a second curve, a new business or a new way of doing business that is radically different from the first. Now, the dirty little secret of futurism is we cannot actually predict the future, right? And there's a natural human tendency to overestimate the impact of phenomena in the short run and underestimate it in the long run. So you commit 2 types of errors. You panic and you walk away prematurely from that old business, only to find you've walked away from all the profit and revenue. And conversely, if you don't start building that second curve, you're not going to be around later on in the 21st century. That's the dilemma that we're now seeing in healthcare. Most industries went through this in the 90s, but now healthcare is having to pay this price. Think Kodak, think Blockbuster, right? You get blindsided by a different way of doing it. Now, the problem is getting from here to there. And that really is why many in the American Hospital Association, my friends there, embrace this concept as the metaphor of what they must do, what health systems must do in the future, starting in 2011, and a whole series of reports that have come out since. They've been describing this move from a first curve where it's pay for volume on a fee-for-service basis, where quality is not either differentiated or rewarded in any financial sense, to a paying for value, where it's either fee for value or something approximate capitation, analogous to my friends at Kaiser. And that's the major shift. I mean, I've been moderating this AHA Leadership Summit every year for the last 20 years, and this is a relentless move from the first curve to the second curve, and we're seeing it happen at scale. Now, I want to just take you a quick tour through the purchasers and differentiate in your mind between short-term and long-term. And I'm going to do this relatively quickly. What I would say is there are sort of 2 competing visions in the marketplace. One is what I call the Berwickian nirvana, named after the great Don Berwick, who's a friend of mine, and a saint in my view. But his notion of large accountable care organization encouraging rationalization of the delivery system versus a much more atomistic view of people in high deductible plans armed with transparency tools, selecting health services in much more of a high deductible consumerist type model. Now, I personally believe we have to reconcile both of these. I think it is useful to have consumer incentives, and I do believe strongly in integration, and that really, I think, is the challenge many of us have going forward. What is clear is that the new environment, no matter what, will put limit on outlier prices, and we are seeing many, many purchasers embrace tools like Castlight, which is a set of tools where consumers know exactly what it's going to cost them to go to Dr. A versus Dr. B, given where they are in their benefit for the year, and given the discounted payment that that physician will actually receive. This is not just stars and bars or Yelp data. This is what it will cost to go to Dr. Johnson versus Dr. Taylor. Now, when we do surveys of consumers and ask them, what is it you want out of this healthcare system? This will be hard to read, but I'll talk you through it. We put them through a trade-off exercise. And we say, do you want this or this? You can't have both. Which would you prefer? And if you do that over a big sample, you reveal relative preferences. And we just did it. This is from last year. We just did it again. I was looking at the data last night to get a chance to update this. But what consumers say they want, and blue, by the way, is those under 65, orange is those over 65. What they say they want is low monthly premiums, they want to keep their current doctors, and they want unrestricted access to all medical technologies, and they see no irony in those statements going together, okay? What are they prepared to give up? Access to prestigious institutions, coverage for a wide selection of brand name drugs, choice of hospitals, access to all brand name drugs at low cost sharing levels. You know, I gave a talk, some of you were there actually at the AACP meeting, and I also gave a talk to the deans of all the academic medical centers in America. This was my first slide, right? There's a real challenge making the case that fancy places are worth the money. That's the short version of what this says. And basically what consumers are saying is, give me something cheaper. Now that's against the backdrop of the employers not being as generous as they once were. We're seeing a redefinition of benefits, benefit buy-down, which is code for, you know, when you hear the word empowerment, it's code for you're on your own, pal, right? So what it is, we're getting out of, corporate America is completely getting out of retiree health benefits, not going to be there. And that's one of the most generous health benefits that have been there for pharmaceutical coverage, particularly for early retirees. They're getting out of that business, and they're getting out of the spousal business in many instances and making spouses pay much more. Because typically for employers, half of the benefits dependents are spouses, and they are the unhealthy half. And so they're doing a lot to try and migrate those folks away to somebody else's coverage. They're looking at exchanges as a possible exit, and I don't mean literally in the short run, but we'll show you some numbers in a second. They're looking at direct contracting with these large integrated delivery systems. We were just talking about this at this retreat in the last couple of days. We had benefit managers from Disney and Alaska Airlines and CEOs of large health systems in California and Minnesota and Washington State talking about how they might work together directly. There was an insurance company in the room too, and they weren't too happy about that. But anyway, but no matter what, employers are encouraging their consumers to shop on the basis of cost and quality using these tools. And they're engaging in a much more activist wellness regime. Some would say Stalinist wellness. This is where you have to do 7,000 steps on your pedometer every day. And if you do that, your premium to you will be reduced by $1,500 a year. That is becoming more commonplace, and I think you're going to see employers being much, much more aggressive in requiring people to do stuff to get the benefits of health insurance. But make no mistake, they are not happy campers. Now, this is not a forecast, but is a measure of their discontent. So it's a question we've been asking. We've been serving employers for 30 years. We've never seen these kind of changes. So the top question is the percent of employers, and by employers, we're surveying everybody from 3 employees to jumbo employers, and it reflects the distribution of employment in America. So my company is actively exploring ways to get out of providing health insurance to our employees, basically doubled in the last 2 years. My company feels it's worth it to pay the penalty associated with not providing employee health benefits rather than providing health benefits to our employees doubled. Now, this is not about Obamacare. It's got nothing to do with Obamacare. It's got to do with the fact that the average American household cannot afford the average premium, right? Median household income in America this year is $52,000. The premium for a PPO for CalPERS in California is $24,000. Does not compute. So, I mean, half of Americans can't afford health insurance without some kind of subsidy. And if you look at what employers are doing, I ran a panel at the AHA on Monday with 3 of my friends, Barbara Waxman from Disney, Sally Wellborn from Walmart, and Ann Boynton from CalPERS. And this sort of gives you a flavor of what people are doing. I've worked with all of these, well, I haven't worked with Darden actually, but I've been to an Olive Garden. I've never. So what GE did, my friends at GE took their health benefit spend down from $3 billion a year to $2 billion. They got everyone, including the unions, to get out of the retiree health benefit business and go to a private exchange for those services. And they've done a very aggressive job with a consumer-directed health plan. Disney is a really interesting company. It's got, You know, half of the workers work in theme parks making minimum wage, and the other half are Johnny Depp. I mean, literally are Johnny Depp. And, you know, how do you manage all of that? And they've basically gone to a large consumer-directed strategy, to the point, though, and Johnny Depp now has to pay a little bit more than the theme park people, but people in the theme parks are paying a third to a quarter of their income, their take-home pay, on their share of their health benefits. That's ridiculous. Walmart, as you know, has done this national Centers of Excellence model where they basically say you can go to your friendly local hospital, but you'll have a high cost sharing, high deductible, high co-payment for cardiovascular care and orthopedics, or we'll put you on a plane with a family member. And by the way, we insist you take a family member along. We'll fly them to Cleveland, and you can have it done at the Cleveland Clinic, or Virginia Mason in Seattle, or Baylor Scott and White here in Texas. Now, what's really interesting is when they send folk for those services, and many folk are electing to do it because it's free, absolutely free as opposed to high deductible, they find between 30 and 50% of the cases are unnecessary. And the receiving institutions say, no, we're not doing it, it's inappropriate. And that gives you an indication, in my view, that 30 to 50% of those procedures being done in most communities in America are not required. And I think you're going to see a lot of attention in this. But I talked to Sally in front of the AHA. She's not sending people to Seattle because they've got shares in the airline. She'd rather do it locally, but it's really a call to action that local delivery systems have to deliver higher performance for these people who are paying the bill. CalPERS is very much on the HMO strategy. Intel is going direct and having a direct relationship with providers and signing a blood oath where quality goes up and costs go down every year over a 5-year contract. That's the kind of model that the purchaser would like. Now, the exception to that is, my friends, I live in Silicon Valley. I give a talk to the benefit managers at Facebook, LinkedIn, Google. Look, they could care less how much this stuff costs. You know, the average age is 12, right? The only thing they spend money on is acne medication, right? You know what they want at Facebook, literally? They want the doctors to come and see them from Stanford. That's no kidding. I mean, Google is actually doing that. The doctors from Stanford are going down to see the patients at Google. All right, so that's the private side. So if you think there's a bastion of relief where you can say, oh, well, I'm not, I hear this from doctors all the time, I'm not going to take Medicare and Medicare. I'm just going to take good private health insurance. Who's going to have good private health insurance in the future, given what I just went through? All right, so let me quickly just say a few things about public purchasers and then the transformation. Medicare Advantage is going to continue to grow. Medicaid is a big deal and a big expansion in the states that are doing it, roughly half of the states. The public exchanges are going to grow. And as we've just said, public employers have a big retiree health benefit problem. They're the ones who still are obligated in this business. But no matter what, we're going to see Medicare and Medicaid as a share of all spending grow over time. That's not a political point, that's a demographic point. And the reason is the following. If you look at what the public say they want, right, and you ask, do you want Medicare the old-fashioned way, or do you want Medicare in a managed care flavor? And people who are currently over 65, 57% say, give me traditional Medicare. Only 29% say, give me Medicare managed care, Medicare Advantage. Well, that 29% is precisely the percent that are in Medicare Advantage nationally, okay? So that's reassuring if you're a survey researcher. What's interesting, though, is the people about to turn 65, it's the reverse. 2/3 of them want managed care. Now, why is that important? Well, because when you put in a Medicare Advantage plan, bed days per 1,000 go from 1,600 down to 900. And that's why these hospitals are seeing enormous reductions in inpatient volume across the country. So we know that we're in two Americas. You know, the blue states expanded Medicaid and embraced state-based exchanges. The orange states were holdouts. And we're seeing these divisions getting sharper and sharper over time. But what I've been urging people to say and think about as a metaphor is that the public exchanges, you know, the press were trying to cover it. Will they get to 7 million? Will they not? And I thought that was a really stupid way to think about it. The metaphor, I think, is the Wright brothers. let's just get this sucker off the ground before we declare that flying is a bad idea, right? And I think we've got it off the ground. I'm sorry. I mean, I know it's not popular in a lot of states, but it's off the ground. And it's going to be very difficult to roll it back, even with these latest court cases. Because 8 million people have got it. 90% of the people who got it through the exchanges were eligible for financial assistance. They picked cheap, as predicted. They've paid their premium, most of them. And unlike the early surveys, the more recent surveys show that 2/3 of them were previously uninsured. We have cut down. Look, there are 10 million Americans today who have health insurance net increase compared to last year. That's the biggest improvement in the uninsured since LBJ. That is a very significant change, and Medicaid is a big part of that going forward. Now, in California, we have been ahead of the curve on this, and the people who got the business through the exchange include Anthem, Blue Shield, Health Net, most of the established players with dominant positions. And Kaiser, I work a lot with Kaiser, are very happy. They announced internally that they got 300,000 new members through exchanges this year, mostly in California. Now, I do fault the president for not explaining how to actually go about getting the stuff on the exchange. What he should have explained, this is how you pick a health plan on an exchange. The first step is decide on the diseases you and your family are going to have in the coming year, right? Then you find the best doctors and hospitals for those diseases, identify which plans offer those doctors and hospitals, and then you select the cheapest plan. Now, if, as is quite likely, there are no affordable plans with all the doctors and hospitals you want, you have to go back up to step one and pick some new diseases, right? Now, a lot of people made fun of the healthcare.gov. It didn't work. I mean, I went on the last day. It worked just fine for me. This is what it said when you went on the website. It said, congratulations, you made it through those annoying security questions. Sorry about the delays. We got hacked by the Koch brothers. What can you do? Good news is, we rummaged around in your IRS records and some stuff we got from the Snowden guy and found out you make $12 an hour. We know you lie about your tips, but we all do, right? If you ever get a raise, you'll be eligible for health insurance through the exchange, which will allow you to buy a very high deductible health plan with a limited network for free. Meantime, the news gets better. You're probably eligible for Medicaid that will provide totally free access to a very limited network of providers, maybe the ones you see now because you're uninsured. And the question is, what state do you live in? Answer, Texas. Good luck with that. Come back when you get a raise, right? So, there are 1 million people here in the state of Texas who fall in that category. 1 million, 5 million nationally, who are too rich to qualify for Medicaid and too poor to qualify for the subsidy. Try explaining that to people in Scotland. Well, you can't, is the point. So Medicaid, big deal in the states that are doing it. In Colorado, I was just there a couple of weeks ago, Medicaid enrollment is up by 1/3. In Oregon, it's up by 40%. So these are very significant changes. In California, we're going to have $90 billion flowing through the Medicaid system in the 2014-15 budget, mostly from the federal government. Medicaid is 30% of folk in California now, so it's a big deal. The other good news is we're seeing reimbursement reform take hold. I was at the United Healthcare National Accounts meeting where they basically said to their employer customers that they're currently spending $30 billion on a pay-for-value type model, and it's going to go to $50 billion of their $100 billion spend within 2 years. I was with a senior executive from WellPoint the last couple of days. Their numbers are very, very similar. Neither of those companies, WellPoint and United, will sign a contract with physicians on a go-forward basis that doesn't have a pay-for-value component. So open-ended fee-for-service is going away. Fee-for-service is moving from fee-for-service to fee-for-value. And it's being accelerated by the fact that these large systems I talked about are starting to take risk. Now, I write a regular column for the American Hospital Association. You can go and read it on my website, ianmorrison.com. But you know, there are different flavors. There are some health plans, or sorry, some health systems who had a legacy health plan that are reactivating it and re-emphasizing it. People like Intermountain in Utah, Sharp, Presbyterian in Albuquerque, Spectrum in Michigan, Providence in the Pacific Northwest. There are systems, very large systems, that in the last 12 months acquired a health plan function, including Partners in Boston, Sutter in California, Baylor Scott White merger here in Texas, and North Shore Long Island Jewish. And Ascension is apparently in discussion. I was at the CEO of CHI earlier this week. Their deal is done. So, you know, CHI is a $13 billion healthcare delivery system, Catholic Health Initiatives. Ascension is a $20 billion system. So we're talking about big players doing this. The most dominant model, however, I think is going to be the third one, which is health plans are in deep commercial ACO partnership or Medicare Advantage partnership with private label Blue Cross Blue Shield or Aetna, United, Cigna, WellPoint, all have big offerings in this space. I think you're going to see that happen more and more risk being taken by these large systems who are going to organize themselves to look a lot more like Kaiser than the traditional fee-for-service model. And they have an advantage because hospitals actually are well regarded amongst the public. If you look at trust, drug companies and health insurance are not. Managed care companies are just above oil companies and tobaccos, and Al-Qaeda is the most hated in America, you know. Now, I think this is a huge opportunity for the clinical pharmacy community because as we move towards capitation, if we move towards volume to value, then it really changes up the way we deliver care. But look, this is not going to be an easy path. When we interview hospital leaders and say, who's on board with this transformation? Well, the CEO's on board, the CFO's on board, the board's on board. There are just three groups who are not behind it yet: doctors, nurses, and patients. You know, apart from that, we're 100% behind the transformation. And it'd be interesting to poll clinical pharmacists to see where they are in this process. I do believe it's an opportunity for you, but I think physicians are frightened, and this is a vision of what the typical medical staff meeting of 2020 is going to look like. You know, everybody's aggressively fighting over this work. But we are seeing movement. We survey physicians, and we find that they're moving towards or away from being the independent resistors. This is the two poles of the segmentation are the blazing believers, where we saw about a third of them in that category last year. It's dropped actually this year. The independent resistors continue to drop. These are cranky old surgeons basically. So we're seeing this migration of physicians who are moving towards, away from rather, just the old model of fee-for-service. So here's what I call the work, and I think you are going to be centrally involved in this work going forward. Everywhere I go, and I see a lot of strategic plans of these large health systems, I see an emphasis on clinical integration, integrating across the continuum of care for higher performance using team-based care, including clinical pharmacists, in end-to-end solutions that improve the health and well-being of the populations that they serve. I see health IT as a platform for all of that, even though it's not a panacea. You know, I was the keynote speaker at the rollout of Kaiser's electronic health record 3 times in the last 30 years. You know, no kidding. I mean, $10 billion later, they got it working. Everywhere I go, people are saying we've got to learn to live on Medicare, which means enormous cost pressures to take costs out in these systems. And the thing they're struggling with is, how do I move from volume to value? How do I make that migration? And by the way, the secret sauce of that, I've just discovered, is that you can do that by managing referrals on a fee-for-service basis. You get fee-for-service fuel to migrate you to taking risk. And what is the consequence of that is the little guys on the other side of that trade are going to get squeezed. You're going to find enormous competition, these large integrated systems keeping more and more and more of their patient activity in-house, particularly if they have a health plan function. And it will be harder, you know, fee-for-service is no more a hunting license to go to any provider. And then the final point I'd make is that all these systems have to build a culture of quality and accountability. And we're not there yet. One of my dear friends, Pete Aaron in Oklahoma, taught me this. He's a physician who leads a CMO of a large integrated system, and he said, Ian, we have all the anatomy of an accountable care organization, but none of the physiology, and that's a wise statement. We've got ways to go. I'm concerned about time here. I do want to make a couple of points, though, about the role of pharmacists, because I think though if you're following my line of argument here, we're going to see more and more systems taking risk, and I think your profession has played a very big role in Kaiser. I was at a meeting recently where one of the top performing Kaiser groups in Colorado were arguing that they were now looking after, 1D Farm had a panel of 900 brittle diabetics that he or she was managing with tremendous data support in a case management system, and their hemoglobin A1C performance was better than any other fee-for-service oriented, disjointed care pattern across the country. So I think you are going to be part of that solution for a number of people. And it will involve doing things differently. Lucinda and I were just talking about this. The punchline of all of this is we got to change up the way we deliver care. And I'll give you two very short examples. One is the refrigerator. So my friend Art Gonzalez in Denver, who runs Denver Health, told me this story that they had a woman who was a brittle diabetic, constantly readmitted, huge user of services, and they are capitated for her care, and they were terribly concerned, and they had met D farms and physicians meeting with this patient saying, why aren't you taking your medications? And she said, well, they have to be refrigerated. Well, I don't have a fridge. They bought her a fridge. She's better, you know. It's a different way of thinking. The truck example was a hotshot hospitalist who told his CEOs, I can cut the readmission rates in half for this hospital. He was Spanish speaking, and he went into the poor neighborhood with this beaten up truck and met with a family, explained what meds they were on and what meds they weren't on. Now that the patient was discharged, had the whole family around grandma to explain that, and the patient responded, the family responded, and readmissions were cut in half. So my point is you are going to play a big role in that transformation. You're going to play a big role in the triple aim. Let me just go to the end here because I'm concerned about not getting you off track in terms of time. And I'll be available, by the way, to answer any questions. The one last thing I wanted to highlight is the role of specialty pharmaceuticals. You know, my friend Joe Swedish, who runs WellPoint, the one thing that keeps him up at night is specialty pharma. Sovaldi, you know, the Gilead product, is the most visible of this, but this is part of a mega trend where pharma spend, we've moved from where, you know, biologicals were a rounding error. It was like 2% of the drug spend. It's now up around 40%, 40 to 50% of the drug spend. And this is an underestimate, in my view, given Sovaldi's success. I think we're going to be well over 50% this year alone, and growing at 20% compound. This is a big number. It's a big problem for health plans. It's a big problem for at-risk providers as well. And you're going to see more and more attention. And I think it presents opportunities for the profession. So I went very fast. I think we're a little bit over time, but not too bad. Look, change is not going to stop. Value matters and affordability is key. Half of Americans cannot afford the premium. The Wright brothers for ACA, I think it's off the ground. I don't think in any scenario are we going back to an unfettered fee-for-service system, even if Obamacare is defeated politically in the upcoming elections over the next 4 years. There are going to be big differences between the two Americas that persist for a long time, in my view, for many political and economic reasons that we've explored. But think about the business like this going forward. There's really going to be three segments: Medicare Advantage and commercial ACO, you know, at-risk type payment models, managed Medicaid, and high deductible and consumer-directed healthcare plans, mediated through exchanges or private companies as the residual third. There is no other kind of unfettered fee-for-service bucket in the future. There will be opportunities to take risks for providers, and there will be not only opportunities, but a requirement for us to redesign the delivery system for higher value, and that includes a focus on heavy users and transforming the performance for those heavy users by meeting them in their life. And the key for people running these systems is to develop the governance and leadership to make it happen. And I see that happening. I do a lot of hospital health system board retreats. I know most of the leaders of the big systems across the country, and they are stepping up to do this. This time they are serious, in my humble opinion. And in terms of your role, I think it's going to grow dramatically. You have a very important set of skills, and you can play an incredibly important role in these integrated delivery systems by leveraging technology and people. And I think that is part of your challenge in transforming the profession. I pray you have some good ideas about how to manage specialty pharma. I think we have some huge issues in this area. We need the cures. We need the science. We want this stuff. But we need as a society to figure out how we pay for innovation, how we manage pharmacy risk, and how we make them available and affordable to people on a go-forward basis. And I think academic medicine is under some pressure, that's the bit I skipped over, in terms of the kind of economics of the system. And I think that probably trickles through to what that means more generally for programs in clinical pharmacy. That's way above my pay grade, but I'm sure you guys will figure out. You do important work. I salute you for that work. I thank you for your attention. And have me back in 10 years and we'll all decide how well it worked out. Okay? Thanks very much.
Thank you, Ian, for making an incredibly complex and changing healthcare system make some sense, and for doing so with a dose of humor. As he said, he will be available in the interest of time during the break over here to answer questions or discuss with you. We have a few final announcements and reminders. I do need to make one comment on a tweet that I saw that said I showed a random horse race. Surely you all recognize the Kentucky Derby, the most exciting 2 minutes in sports. Okay, final announcements. We very much appreciate our exhibitors' support and look forward to the exhibitors' opening reception and the first research education poster session this afternoon from 4:30 to 6:30. The second exhibit session is tomorrow from 9 to 1:30 with a box lunch in the exhibit hall from noon to 1:30. Don't forget your tickets. Also, along with your registration packet, you received an exhibit hall passport. Visit exhibit booths throughout the hall to get your passport validated so you can be entered into AACP raffles for exciting prizes, including Apple iPads, Garmin VivoFit fitness bands, Amazon gift cards, and much more. I encourage you to join us for the 2014 Science Plenary on Monday, where you'll learn how big data will change the future of healthcare practice and research. You can also check out Dr. Butte's TED Talk online. This year we have video interviews of all 4 of our top award recipients and our Student Engaged Service Award winners programs. These have been uploaded to the AACP YouTube channel, and they will be playing on the large screen in the registration area. Each one is special and informative. And of course, we look forward to seeing everyone at the closing banquet. Please note there is no reserved seating at this event. Seats will be available on a first-come, first-served basis. And remember, even though you'll be dressed in cocktail attire, you still need to wear your name badge. We have an amazing few days ahead, and when you do return home, remember that you can take advantage of the AACP Online Learning Center. As an annual meeting registrant, you receive access to all the recorded sessions, including more than 50 hours of continuing education for just $100. We're about ready for a break. After refreshments, everyone is invited back at 10 a.m. for the first session of the AACP House of Delegates. We'll hear a variety of important reports, including a presentation by AACP President-elect Pat Chase about association priorities for the year ahead. Delegates, please sit in front to facilitate the conduct of business. Don't miss it. And this concludes the opening general session of the 2014 AACP annual meeting. Thank you.